Amiodarone is also in a pill that can also be given IV for a patient. It used to only be used for ventricular arrhythmias, but now we also use it for patients with recurrent or refractory atrial fibrillation. This is a drug that's not without cost, because this one is one you always have to bring a patient in the hospital to start them on. Always. Amiodarone has a half-life of 4 days. So if I'm going to put a patient on this medication, I have to have them in a hospital, have them on a monitor so I can see what it's doing to their heart, to their rhythm, because I can actually keep widening them out till they don't do anything. You got to put them on a pacemaker. So that's the issue that you have. Okay, so it can be one that you see used for atrial fibrillation, but it's never the first line drug. It's usually after the patients come in, this may be the third bout of AFib, and now I'm going to start using this drug. But it's not the first line one. But we always have to anticoagulate the patient. You're always looking for signs and symptoms that they're experiencing complications, because the clots can go off and they lodge in the brain, which are going to be stroke symptoms. They can lodge in the heart, which is MI. They can lodge in the lungs, which is PE. DVTs, if you start seeing problems with circulation, all of those things are happening because these clots are just going off to different parts of the body. So you got to be looking at that. Those are the complication piece that goes there. So atrial fibrillation, you got to know. That's one you want to look at. Okay. Now we have ventricular tachycardia. Okay. Also known as VTAC, as you hear people talk about it. All right, VTAC is retarded. I'm just saying. More retarded than me. All right, because VTAC exists with a pulse. And without. Why that's important is because if I'm using electric, because I just did drugs for atrial fibrillation, we're going to talk about how you can use electricity. So that's why it's important to look at what's happening with VTAC, if it's pulseless or if the patient has a pulse. Okay? So ventricular tachycardia tells you that's the ventricles of the heart. The pumping force of the heart is being affected. Wide, bizarre QRS complexes are what you see. But when you hear people or they're talking to you in your report, and you listen to people talk about, oh, the patient had a 4-beat run of VTAC, or the patient had an occasional PVC. Anytime you see QRS complexes that are wide, it tells you the heart is irritable, which is not a good thing. You know, it's just like you when you're hot. Well, I'm when I'm hot. I'm irritable. Okay. So patients going along with their normal heart rhythm, with a narrow QRS complexes, and then they have a PVC. A PVC says they have a premature ventricular contraction. Always produces wide and bizarre QRS complex. Okay. One of those is a PVC. When you put them together, when two of them together, what are two people? So they're couplets. If it's 3, triplets. See, you're doing all the rhythm stuff in your head right now. You know it, all right? So if you have 2 of those together, so if I did 2 of these, that would be a couplet. And if I did 3 of them, I'm just going back to my regular rhythm now, okay, for this person. So that's what they're looking at. You know, the thing about it is when that monitor tech is sitting there, they're looking at how many of these are happening. How many are happening in a minute's time. So if they're rare, that tells you they're not happening that often. You still become CSI. You're trying to figure out why they happen. Because they can be electrolyte imbalances, it could be medication, different things the patient is taking, but you need to know that. So if it's rare, that's a good thing. It's bad, but it's rare, I can deal with that. All right? If they're occasional, telling you they're starting to happen more frequently, then you really need to look at what's going on with the patient. Did I look at their electrolytes this morning? They had some lab work done, and they get diuretics, and we didn't check the potassium, because that's a lot of times what the problem is, or the magnesium. Could that be the problem? So make sure you look at the electrolytes for your patient. If they're frequent, tells you the heart is really irritable. I need to fix this now because I can end up doing bad things, really bad things. Okay? So when you see them and you never want to see them But the thing that makes them different is wide bizarre QRS complex, because that should be 3 boxes, narrow. When you see wide and bizarre, it tells you PVC. When you string them together, that's VTAC. Okay, so instead of doing 2, and they'll count them. This little section is here is what they call VTAC, and they'll count them. 5-beat run, that's how they tell you when you listen to a report. They're telling you how many they string together. I have had patients who do that all the time. You go in the room and you're going like, I don't know how you're still here, because you should be coding or something, because you've been doing this for the last hour. People do different things based on what their heart can tolerate or what they've been doing. I'm just telling you, they can go all over the place. But you can have some people who do 2 of these and pass out. It will always depend on the patient. But this I need to fix, because this tells me heart is irritable. I don't need to be thinking about it. I need to be proactive in trying to figure out why this is happening with the patient. Because that tells me heart is irritable. It is something you generally see after a patient has a heart attack. One of the most common arrhythmias to happen after an MI. And that tells you the heart is irritable. It's not being perfused. The metabolism of the heart changes, therefore the patient ends up having this problem. So that can very well be what you see when a patient has an MI. Okay, but I need to fix this. Now the reason I say it's retarded is because this can have a pulse. Okay, that means that I go in and check the patient, they have a pulse, I feel it, I can hear it. Although the heart rate is really fast, it's hard to discern how fast the heart rate is a lot of times because it's going so fast. Because generally when you talk about VTAC, patient's heart rate is between 150 and 160. Okay? That's a lot. When you think about how fast that is, trying to listen to a person. But in your head, think about it. If my heart is beating that fast, is it filling fully? Is it pushing enough out? Think that that's what happens to your patient. That's why they have changes in the level of consciousness. That's why blood pressure is low. You can think about if this is what's happening with the heart, this is why I see these symptoms in the patient. Okay. So I got to fix this in the patient. But if they have a pulse, VTAC with a pulse means I can feel something, whether it's weak and thready, they have it. Blood pressure is low, but I have one. Okay, so it's bad, but I got time to work. I don't have much time, but I got to work on it. Okay, so blood pressure can be 70/40, but at least I got one. Okay, so VTAC with a pulse means I have a pulse and a blood pressure, no matter how bad it is. Barely if I can feel it, because it's that fast, but I feel it. Blood pressure is very low, but at least I have one. Okay. Then there's VTAC with that's pulseless VTAC. So that's a dead person. Okay, so you see VTAC on a monitor, but when you feel them, no pulse. When you check their blood pressure, no blood pressure. The reason that's important because we treat them different. So we're going to talk about electricity in a minute. Okay, because I just talk about it all together when we do that. All right. So VTAC, I got to figure out what's happening with a patient, whether I have a pulse or whether I don't. But medications that I might give to this patient are lidocaine. Now you know about this one. That's what happens when you go to the doctor's office, the dentist, and he numbs your teeth. Same medication. Okay, so it's xylocaine that they use. It's a numbing agent, and what it does is help to get rid of some of the irritability that's there. You don't like to use that lidocaine for a long time. You do it during the code or when the patient's having a problem, but you don't like to infuse over a day. Mainly because it has an active metabolite that can change to cyanide. Kill folks. All right. So you want to try to figure out why it's happening. We use it for that immediate period. It also causes paresthesias. Think about it. If you're infusing in somebody's arm, guess what? It's a numbing agent, so that sometimes can interfere with what's going on. They have a central line. It's a lot easier. If it infiltrates, you wouldn't know. Because guess what? Patient's arm is numb, and it can be this huge. But it's okay. I don't feel a thing. That's where they're going to look at you, kind of thing. All right. So lidocaine is something that we use. That amiodarone comes back because that's something that we use for ventricular tachycardia.
And this is without pulse.
No, this is just some of the medications.
Ms. H, the lidocaine is initially used for what? To numb the...
It's going to help you get rid of the irritability that's there.
Oh.
Because that's what the major problem is. You still need to figure out, because remember, CSI always comes in here. You're going to figure out why the patient is having it. Is it post-MI? Is it because the patient took some type of methamphetamines? Because those are notorious for doing that. You know, look at drugs that the patient might have taken. So yeah, you're going to do that. Or it can also be electrolyte imbalance. That's the bad part, is that you can do all of those things, but you got to try to figure out what's going on with the patient. You got to correct those. But for the immediate period, what I'm trying to do is get rid of that irritability that's in the heart. So amiodarone can be here. Some of the other things you see given are Tepicin. I remember when all these drugs came out. That's how old I am. But we used to have to get like 4 consent signs, because when we first used them, we killed folks too. Because we figured out, oh, you need to correct some of your electrolyte imbalances before giving the meds. But of course, a new drug, we don't know that till people die. That's sad, but that's the way it ends up working. So you can see that given to a patient. Okay. Some of the other things that you may see the patient take pill-wise. Now this one here has a pill. All right, but these are things that you usually use during an acute phase. But if you got a person that keeps coming back and that kind of stuff, these are the stuff they usually go home on. Tepicin, which is also, like I said, one of those drugs that we find out that treats those arrhythmias, but you have to bring the person in the hospital for that. Rhythmol and Beta-Pace, you also have to do the same thing. Beta-Pace also has a 4-day half-life, so it's a beta blocker, solatolol. But it's usually done as a last resort because the half-life is so long for that particular drug. But that's something that we can use for treating those. So if you talk about medication, those are the kind of things we're looking at. Lidocaine we can use initially because that's what you're going to, in a cold situation, they give it as a bolus and then they put them on a drip. Then we try to get them off that and put them on amiodarone. That's usually how that progression works about what's happening with your patient. And then if we can convert them doing that and get them out of that irritability, make sure we're doing the CSI part to figure out why it's happening with the patient. Sometimes it's something that's going on inside the patient, we got to fix that. So we'll talk about that when we talk about the EP study kind of thing. But that's the VTAC. So it exists with a pulse and without. It will look the same on a monitor, but always remember you treat the patient, not just the monitor. So that's why you feel for a pulse in the patient, you do a blood pressure. One of the things, especially for those of you who do ACLS, they will let you code a patient for 20 minutes and you're going like, wait a minute, I've done everything. I know I've got this protocol. You know that's what it is. Remember the protocol down to everything. And the reason that they keep letting you code the patient is because you have not asked, do I have a pulse? Do I have a blood pressure? They're going to let you just keep doing it. And you're going like, wait a minute, I gave every med there is. And we're starting over on meds. And by this time, I'm giving bicarb. Because bicarb used to be a thing we gave a lot. Now we give bicarb at the end of the code because it's mostly acidosis that's the problem. So you give them like 6 amps of bicarb, you're going like, wait a minute. Either this person ought to be dead or what else is going on kind of thing. And they'll tell you after you fail that you didn't ask if I had a blood pressure or a pulse. So always ask that question. Because they know you're looking at all those things for the patient. So that's VTAC, okay? Now ventricular fibrillation is only without a pulse. Basically what you have here is chicken scratch. That's what it looks like. You don't see any P wave, you don't see any complex, you don't see T. It's basically just chicken scratch going across. It can be very fine or it can be coarse. It's depending on how long it's happened with the patient. This is one of those things where they always talk about treat the patient, not the monitor, because this is definitely something you need to go treat, but it can also be produced by somebody brushing their teeth, by somebody in the bathroom shaving with an electric razor. It looks exactly the same way. You go down to the room with the cold cart, bust in the bathroom, the patient go like, what?
So why is that?
It's just it's an interference. Because see, remember, you got a monitor on you. If you're doing stuff like this, it interferes with the monitor. So you're going to see it going. Always go. It could be the real thing, but always that's why you go treat the patient, not the monitor. Take the cold cart down there because you might need it. But a lot of times it's patients doing stuff. So just know that. That's why they always tell you treat the patient, not just the monitor. So you're looking at that. So ventricular fibrillation tells me I have no cardiac output. So VFib is always going to be pulseless if it's real.
What's the different view of picture of ventricular fibrillation and atrial fibrillation?
With atrial fibrillation, because there's no QRS complex here. Because remember, with atrial fibrillation, you do this, and then you have a QRS complex. And then it's going to be irregular, but you at least have a QRS complex. With VFib, they don't have that. There's no cardiac output going on with this patient. That's a dead rhythm. Okay? So no pulse, no blood pressure. Guess what? Your medications are the same, but the thing about it is I got to shock this person. They need electricity. I need to jump start the heart. So that's when you take your defibrillator off the cold cart and you shock the patient. Okay, that's what the AEDs, when you're all around, it's diagnosing the rhythm on the patient, it's going to give a shock. Okay, so this is the electricity piece, defibrillation and cardioversion. And there's a nice explanation of it in those papers I handed you out about. Now, if we use medications, you know, those are things that we can use to try to convert people, but if we're going to use electricity, and electricity is usually going to be used if a patient is very symptomatic, and I need to reverse this right away, or I can kill a person, or I let them keep getting worse. Hemodynamic stability is the issue that we're looking at for this patient, except for the AFib, because remember I got to anticoagulate them first. I can't just do this for them until they're anticoagulated. Because you'll notice if I have a person in AFib who's in the hospital and I'm going to do cardioversion, I anticoagulate them first and then I schedule them for cardioversion. It's not something you do at the same time because I need to make sure this person isn't throwing a clot. Okay, so just know that electricity is something that can change your rhythm quickly, but I don't do it with atrial fibrillation. You can do it, but it's got to be later till they get okay in their PTT. If it's in that therapeutic range, then I talk about doing that for a patient. Everybody got that? All right, so cardioversion, because you know how you remember stuff. All right, cardioversion is done for live rhythms. Defibrillation, D, is done for dead rhythms. That's how you can remember that, okay? Cardioversion, a live rhythm means I have a blood pressure, I have a pulse, no matter how low, no matter how weak and thready. That's a live rhythm. I got something to work with. That's cardioversion. Okay. So I'm going to switch this to something the person has around. I feel this. They're symptomatic, meaning blood pressure is low. Change the level of consciousness. That's when you start using electricity. I need to turn this around. Get the heart back to pumping like it should. But you can only do cardioversion with a live rhythm. The other thing that you do is that this goes into sync. There's a little button on there, on your defibrillator that says sync. Because one of the things that you'll see if a patient has this as an elective kind of thing, it says have patient sign consent for elective cardioversion. Okay. Synchronized cardioversion is usually what's added in there because that's what you have to do. The sync stands for synchronized. In your head, think about all those boy band groups. For old people, think about the Temptations or Gladys Knight and the Pips. When they're performing on stage, how are they moving? All together, synchronized. That's what's going on. When you put the sync mode on, it's going to only deliver electricity on the R wave. Okay, so when this is what's going to happen. You'll see it. The monitor strip go on. The R wave is the top up here. So this is P, Q, R, S, and T. When you're looking at your waves. The P wave is atrial. That first downward deflection is the Q. R is at the top. Think about ET. His finger lights up. I'm really old, so I'm telling you, because ET is probably like 40 or something, I don't know. But when you see his, if you ever see that movie, you see his finger when he raises it up, it lights up on the end. When you put a machine in sync mode, it lights up the R waves. So even if I deliver the shock, it's only going to deliver on the R wave. It's going to wait until it gets to the R wave, because that is okay. If I deliver it anywhere else, I cause problems. So put it in sync mode. It's going to deliver your energy on the R wave. Always make sure when you're given, if you are in a code situation or you are going to be doing synchronized cardioversion on a patient, you know, and the nice thing about it is they have pictures, so you don't have to, one goes here, one goes on the side, so they have pictures of that for you. But the thing about it is you're going to say that I'm clear, you're clear, everybody's clear before you deliver the electricity. Anybody in contact with the bed can be shocked. So that's why you always say that. I'm clear, you're clear, everybody's clear before you deliver the shock. Now the thing about it, you push those buttons, it's still going to wait till it gets to an R wave to deliver electricity. What you see is you'll see a drop off and then it'll start coming back. And hopefully you put the patient back in the rhythm, a nice rhythm. But sometimes it doesn't work, you may have to increase the electricity and do more. But those are things that are always directed by somebody. Not saying you got to remember all of that, but just know that if I'm going to use electricity, there's hemodynamic instability is the problem. I can use it on people who have a live rhythm, put the machine in sync, and it delivers your energy on the R wave. You still have to go back and figure out why it's happening in the patient, but I can correct this, hopefully, with one shot. Now, I will tell you that even if it delivers on the R wave, sometimes you kill folks. They go into asystole and stuff, because people do some of everything when you shock them. The vast majority of people do stuff you expect them to do, but every now and then you get somebody that does crazy things. Okay? But just remember, cardioversion is for live rhythms. Defibrillation kind of tells you what it's for. It's a dead rhythm. I don't care where I deliver the shock. I'm just trying to jumpstart you. Think about a dead battery. It doesn't care where it gets the energy from. It just needs it. So a dead rhythm gets defibrillated. So that's pulseless, VTAC. VFib. No pulse, no blood pressure. Now, asystole is like that, but asystole is not a shockable rhythm. Asystole is I need to do CPR and then try to figure out what's wrong with the patient. But ventricular fibrillation is shock rhythm. If the patient doesn't come out, we increase the joule, shock them again. If they don't come out and they're still in that, you increase the joules again. 200, 300, 360, that's ACLS.
Huh? Is it the same machine?
Same machine. All you do is increase the electricity.
Oh, okay.
Yeah, the thing about it, that's the other thing. When you're doing defibrillation, you have to take it out of sync mode. Because otherwise it keeps looking for R waves.
And that would be like,
Exactly. So all you do is that when you take that, when you push that button, it'll come out, and then it's just going to deliver the shock. Okay, because if I need it now just to give the shock to the patient. I don't care where it happens. But when you're doing sync cardioversion, it always has to be in sync mode. But defibrillation, dead rhythm, just think about jump-starting your battery. You don't have to go out there and figure out, do I need to put it on the other side of the fence or this particular side, I just need to shock it. But if the person doesn't come out, the one thing that shows you patients live longer is to shock the patient early and often if you need to. That's what's going to help as far as decreasing mortality associated with the patient. Yeah.
Do you start with defibrillation and have to do a cardioversion, or is it like one or the other?
No, it depends on what you're doing. Now, if I had a patient who I was doing a cardioversion on because I had a pulse, now, like I said, I put it in sync mode, everything looks like it's going okay, and you shock the person and they went to a pulseless rhythm, you got to take it out of sync and do defibrillation. Most of the time it doesn't, you're not, it's not that you're planning on doing the other one, it's because it's a complication that happens. Defibrillation is usually done because it really is a patient pulseless. They were doing ventricular stuff before, so you already got a suspicion that that's what's happening with the patient. But a lot of times if you shock them, they do come back. That's the good thing. But if it's a cold type of situation or the person was out for a while, you may be shocking them for a while. But if you come upon them, that's one of the things that the AED does for you, is when you put that on a person, it'll say diagnosing rhythm. That's essentially what you're doing when you put patches on a person, or you put paddles on them, is seeing the rhythm that the patient has. And then based on that, the machine delivers the electricity. Now, if it's a patient who is unresponsive because they can't talk to you, you don't have to worry about feeling the pulse when you're using an AED. It's doing it for you. If it sees that the person is in VTAC, it's going to deliver defibrillation. If it sees that the person has a rhythm, then they're going to do cardioversion. The machine does it automatically when you're talking about AEDs.
Well, it'll tell us if we have to do cardioversion when we have to press this thing, or automatic.
No, and if you're talking about AED, it does it on its own. If you were doing it in a patient, part of what happens in the code situation is somebody seeing whether this person has a blood pressure or not. And if they don't, then you're going to be doing defibrillation. If they do have a blood pressure, then you're going to be doing cardioversion. So it always dictates what kind of dictates what you're doing is whether the person has a pulse and whether they have a blood pressure. But that's the electricity that you use for those. But it's the same machine. It's just that when you're doing cardioversion, you have to put it in sync mode. When you're doing defibrillation, you have to take it out of that because sometimes it does happen. The issue that you have, and the reason why I was talking about that Q on T thing, if you had a person who did have a pulse and you did not put that in sync, it would deliver it anywhere. And if it delivered it on the T, then it usually puts you into VFib. Okay, so that's the reason why you have to be careful about what you're doing, looking at the patient. So that's what the Q on T usually does, is put people into VTAC, or it does torsades, which is when you talk about patients who have crazy rhythms. Torsades de points is one of those. Torsades is a patient who has a ventricular tachycardia, so you'll see this, but you'll see it turn on its axis and they'll do all this kind of stuff. That's a very ominous rhythm because it's usually if somebody's going to die kind of thing. If you don't treat this and figure out why it's happening, patient usually dies. And it's called torsades de points because it's the points turn over. That's why they call it that. So you'll have a person that has VTAC going in one direction and then it turns over and goes in another opposite direction. That usually precedes ventricular fibrillation. So if you don't fix it or figure out why it happens, or sometimes if you're blessed enough to catch it, you see it happening on the monitor and you're like, oh my God. We go down there and shock the patient. You shock the patient, they wake up going like, what the kind of stuff to you. We've done that a couple of times in the hospital. You go down, you see it happening, you can take the code card down, put the patches on the person because they're unresponsive, and you shock them, and they go like, what are you doing? When they wake up, because it feels like somebody kicked them in the chest. They'll tell you that. So what are you doing? I'm like, I'll save your life. It's okay. We'll be up. But then you have to transfer them to the unit, because that's, we need to figure out why that's happening. And a lot of times it's electrolyte disorders. It can be magnesium, potassium kind of stuff going on with patients. But that's what you'll see, and the rhythms you got to kind of look at to see what's happening with your patient. But electricity is one you can use. Torsades is never a good one. If you ever see that, it's like, that's not a good thing ever to see. But you can use electricity to convert them as well. Now the other thing that you're going to do, because we talked about some of the lab work you do as far as doing your thyroid testing, but you're also going to do electrolyte testing so that I can see whether or not there's an issue with patients have a problem with their electrolytes. Primarily, you're going to see magnesium, potassium, that are the major culprits when you're talking about that happening with your patient. You can also do an EP study. Which is your electrophysiology study. And what they're doing is going in and looking at the electrical system of the heart. So it's a really very expensive EKG kind of thing. But they're also looking at the conduction pathways that go along with the heart. Because what's weird about myocardium as opposed to other muscle is that every single cell in the heart can initiate an impulse, can conduct an impulse, okay, it has refractoriness. Those are things that are unique to cardiac muscle. Because normally when you talk about, we move around and don't even think about it, but it the impulse follows along the muscle across a synapse to the end of to the other muscle. That's how things run all the time. But cardiac can say, hey, I don't like the way you're running that, so I'm going to go my opposite way. So that's what sometimes produces arrhythmias in patients. So when I do the electrophysiology study, I can find where that extra little hard-headed person is in there that's causing these issues. Okay, so if you have a person that has a VTAC or something, they're symptomatic, that kind of thing, electrophysiology study is going to tell me where this person has this problem coming from. If you have a person that has VTAC and they're different looking, because that's the one thing that kind of tells you, when a person has an area in the heart that is the problem, the arrhythmias look the same. So when you hear people saying that, oh, I have a multifocal PVC, that's telling you they're coming from more than one place. The more odd they look, or however many different ones you see. So if I only see one, that's bad. But if I see 4 and 5 different looking PVCs, that tells you the whole heart is irritable. That's a bad thing. So you got to get rid of those things that are happening in your patient. But the electrophysiologist